Welcome to the Dr. Izzy's Medical Podcast channel.
Cushing's disease is one cause of Cushing syndrome characterized by increased secretion of adrenocorticotropic hormone from the anterior pituitary. This is most often as a result of a pituitary adenoma or due to excess production of hypothalamus corticotropin-releasing hormone that stimulates the synthesis of cortisol by the adrenal glands. Pituitary adenomas are responsible for 80% of endogenous Cushing syndrome, when excluding Cushing syndrome from exogenously administered corticosteroids. The equine version of this disease is pituitary pars intermedia dysfunction. Signs and symptoms. The symptoms of Cushing's disease are similar to those seen in other causes of Cushing syndrome. Patients with Cushing's disease usually present with one or more signs and symptoms secondary to the presence of excess cortisol or adrenocorticotropic hormone. Although uncommon, some patients with Cushing's disease have large pituitary tumors. In addition to the severe hormonal effects related to increased blood cortisol levels, the large tumor can compress adjacent structures. These tumors can compress the nerves that carry information from the eyes, causing a decrease in peripheral vision. Glaucoma and cataracts also may occur in Cushing syndrome. In children, the two main symptoms are obesity and decreased linear growth. The clinical diagnosis must be based on the presence of one or more of the symptoms listed below because the syndrome itself has no true pathognomonic signs or symptoms. The most common symptoms seen in male patients are purple striae, muscle atrophy, osteoporosis, and kidney stones. Diagnosis. Diagnosis is made first by diagnosing Cushing syndrome, which can be difficult to do clinically since the most characteristic symptoms only occur in a minority of patients. Some of the biochemical diagnostic tests used include salivary and blood serum cortisol testing, 24-hour urinary free cortisol testing, the dexamethasone suppression test, and bilateral inferior petrosal sinus sampling. No single test is perfect and multiple tests should always be used to achieve a proper diagnosis. Diagnosing Cushing's disease is a multidisciplinary process involving doctors, endocrinologists, radiologists, surgeons, and chemical pathologists. Adrenocorticotropic hormone blood test. Once Cushing syndrome has been diagnosed, the first step towards finding the cause is measuring plasma adrenocorticotropic hormone concentration. A concentration consistently below 1.1 picomoles per liter is classified as corticotropin independent and does not lead to a diagnosis of Cushing's disease. In such cases, the next step is adrenal imaging with CT. If plasma corticotropin concentrations are consistently above 3.3 picomoles per liter, then corticotropin-dependent Cushing syndrome is most likely. Any intermediate values need to be cautiously interpreted and a corticotropin-releasing hormone test is advised in order to confirm corticotropin dependency. If corticotropin-dependent Cushing syndrome is determined, then the next step is to distinguish between Cushing's disease and ectopic corticotropin syndrome. This is done via a combination of techniques including CRH, high-dose DSD, VIPSS, and pituitary MRI. Dexamethasone suppression test. Two dexamethasone suppression tests are generally used, the overnight test and the 48-hour test. For both tests, a plasma cortisol level above 50 nanomoles per liter is indicative of Cushing's disease. However, 3 to 8% of patients with Cushing's disease will test negative due to a retention of dexamethasone suppression abilities. For non-Cushing or healthy patients, the false positive rate is 30%. The 48-hour DST is advantageous since it is more specific and can be done by outpatients upon proper instruction. In the high-dose 48-hour DST, 2 mg of dexamethasone is given every 6 hours for 48 hours or a single dose of 8 mg is given. This test is not needed if the 48-hour low-dose DST has shown suppression of cortisol by over 30%. These tests are based on the glucocorticoid sensitivity of pituitary adenomas compared to non-pituitary tumors. Adrenocorticotropic hormone stimulation test. An adrenocorticotropic hormone stimulation test involving administration of corticotropin-releasing hormone or another agent can differentiate this condition from ectopic adrenocorticotropic hormone secretion. In a patient with Cushing's disease, the tumor cells will be stimulated to release corticotropin and elevated plasma corticotropin levels will be detected. This rarely occurs with ectopic corticotropin syndrome and thus is quite useful for distinguishing between the two conditions. If ectopic, the plasma adrenocorticotropic hormone and cortisol levels should remain unchanged. If this is pituitary related, levels of both would rise. The corticotropin releasing hormone test uses recombinant human or bovine sequence corticotropin releasing hormone, which is administered via a 100 microgram intravenous bolus dose. The sensitivity of the corticotropin-releasing hormone test for detecting Cushing's disease is 93% when plasma levels are measured after 15 and 30 minutes. However, this test is used only as a last resort due to its high cost and complexity. Imaging. A CT or MRI of the pituitary may also show the adrenocorticotropic hormone-secreting tumor if present. However, in 40% of Cushing's disease patients, MRI is unable to detect a tumor. In one study of 261 patients with confirmed pituitary Cushing's disease, only 48% of pituitary lesions were identified using MRI prior to surgery. The average size of tumor, both those that were identified on MRI and those that were only discovered during surgery, was 6 mm. Inferior petrosal sinus sampling. IPSS, inferior petrosal sinus sampling, or BIPSS, bilateral IPSS, is a more accurate but invasive test used to differentiate pituitary from ectopic or adrenal Cushing syndrome. A corticotropin gradient sample via BIPSS is required to confirm diagnosis when pituitary MRI imaging and biochemical diagnostic tests have been inconclusive. A basal central, peripheral ratio of over 2:1, or a ratio over 3:1 when corticotropin-releasing hormone is administered, is indicative of Cushing's disease. This test has been the gold standard for distinguishing between Cushing's disease and ectopic corticotropin syndrome. The BIPSS has a sensitivity and specificity of 94% for Cushing's disease, but it is usually used as a last resort due to its invasiveness, rare but serious complications, and the expertise required to perform it. Urinary free cortisol test. Another diagnostic test used is the urinary free cortisol test, which measures the excess cortisol excreted by the kidneys into the urine. Results of 4x higher cortisol levels than normal are likely to be Cushing's disease. This test should be repeated 3 times in order to exclude any normally occurring periods of hypercortisolism. The UFC test has a specificity of 81% and thus has a high rate of false positives that are due to pseudo-Cushing states, sleep apnea, polycystic ovary syndrome, familial glucocorticoid resistance, and hyperthyroidism. Late-night salivary cortisol test. The late-night or midnight salivary cortisol test has been gaining support due to its ease of collection and stability at room temperature, therefore it can be assigned to outpatients. The test measures free circulating cortisol and have both a sensitivity and specificity of 95 to 98%. This test is especially useful for diagnosing children. Treatment. The first-line treatment of Cushing's disease is surgical resection of adrenocorticotropic hormone-secreting pituitary adenoma. This surgery involves removal of the tumor via transmoidal surgery. There are 2 possible options for access to the sphenoidal sinus, including of endonasal approach, through the nostril, or sublabial approach. Many factors such as the size of nostril, the size of the lesion, and the preferences of the surgeon cause the selection of one access route over the other. Some tumors do not contain a discrete border between the tumor and pituitary gland, therefore, careful sectioning through the pituitary gland may be required to identify the location of the tumor. The probability of successful resection is higher in patients where the tumor was identified at initial surgery in comparison to patients where no tumor was found initially. The overall remission rates in patients with microadenomas undergoing transmoidal surgery are in range of 65% to 90%, and the remission rate in patients with macroadenomas are lower than 65%. Patients with persistent disease after initial surgery are treated with repeated pituitary surgery as soon as the active persistent disease is evident. However, reoperation has a lower success rate and increases the risk of pituitary insufficiency. Pituitary radiation therapy is another option for treatment of postoperative persisting hypercortisolemia following unsuccessful transmoidal surgery. External beam pituitary RT is more effective treatment for pediatric Cushing's disease in children with cure rates of 80 to 88%. Hypopituitarism, specifically growth hormone deficiency, has been reported as the only most common late morbidity of this treatment. Growth hormone deficiency has been reported in 36% and 68% of the patients undergoing post-pituitary RT for Cushing's disease. Bilateral adrenalectomy is another treatment that provides immediate reduction of cortisol level and control of hypercortisolism. However, it requires education of patients, because lifelong glucocorticoid and mineralocorticoid replacement therapy is needed for these patients. One of the major complications of this treatment is progression of Nelson syndrome, which is caused by enhanced level of tumor growth and ACTH secretion post-adrenalectomy in 8 to 29% of patients with Cushing's disease. During post-surgical recovery, patients collect a 24-hour urine sample and blood sample for detecting the level of cortisol with the purpose of cure test. Level of cortisol near the detection limit assay corresponds to cure. Hormonal replacement such as steroid is given to patients because of steroid withdrawal. After the completion of collecting urine and blood samples, patients are asked to switch to glucocorticoids such as prednisone to decrease symptoms associated with adrenal withdrawal. Mitotane is also used.
Thank you for listening Dr. Izzy's Medical Podcast Series. If you want to support this project, please subscribe the channel and like this video. Thank you.